I have one more question.
Yeah.
You mentioned endarterectomies need to be done within 2 weeks. Have you had any problems, or are all carotid ultrasounds considered urgent if they're seen in the emergency department? And how quickly are these people getting their Dopplers?
Okay, I guess another point I should have alluded to. The reason we've got them sitting in those lazy boy chairs all day is we do all of the imaging in-house that day. So during the course of the day, we might do a diffusion-weighted image, a carotid ultrasound, and a CT angiogram. And although that sounds like a lot, it's what you need to do. Carotid ultrasounds are the hardest modality for us to get. CT angiography is much easier to get, and it's much better. So if you're having trouble getting carotid ultrasound, go for CT angiography. If you get pushback from radiology, then they need to see some of the data that demonstrates that doing something quickly is important. And our vascular surgeons are entirely on board with this. So we're moving to the majority of our patients that are operated on are acute patients. The data for operating on a non-acute patient is not at all supportive. So it doesn't make sense to put a lot of your surgical resources into non-acute carotid disease because the impact is small to negligible.
Okay, thank you.
Anything further from Surrey?
No, thank
Richmond. Richmond?
I have one question. In regards to your timing around TIA, so-called completed stroke, is that timing of 2 weeks, is that influencing timing for carotid endarterectomy for people who've got so-called completed stroke?
Yeah, that's a good question too. The problem with carotid endarterectomy in somebody who has a significant deficit is that you could worsen the existing lesion. Also, in some respects, at least we know that the recurrent stroke rate in completed strokes, that is the more severe stroke, tends to be less. So it's sort of like, it's happened, it's done. So our urgency for carotid endarterectomy is reduced if there is a significant stroke, and taken to its sort of taken to the end of that argument. That is, if you have a very big stroke, you're really the horse is bolted anyway. Have you got very much brain to save? Are they already very disabled? So the indications for operating become less with somebody who's got more of a devastating stroke. So yeah, if it's a significant stroke, we would wait a little longer.
Just everyone make sure their mutes are on if they're not speaking, please. We're hearing a lot of lunch being shuffled. Sorry about that. Anyway, so now moving on, if Surrey had no more questions and Richmond had none more, Vancouver.
No, we're okay here, thank you.
Nanaimo.
Yes, I've got a clinical question. On your slide for the treatment of stroke, the drug treatment of stroke, you mentioned clopidogrel, but you didn't mention aspirin. And I wonder if you could just, and then later on when you were answering a question, you mentioned dual platelet therapy. I wonder if you could just discuss the role of aspirin here.
Yeah, I think the reason for that slide was because clopidogrel is a prescribed drug, they were looking at the uptake. So this is purely an indication of how quickly a prescription was used, not to say that aspirin was not indicated. When I said dual antiplatelet, I meant aspirin and clopidogrel. So the data that supports the use of dual antiplatelets in stroke is not robust, and in the long term is not there at all. There is no indication for long-term use of aspirin plus clopidogrel in stroke prevention because it doubles the hemorrhage rate in brain and in gut, and it doesn't impact the ischemic stroke rate. The only part of the data that looks like it has got some impact is in the first month after a TIA or stroke. So in other words, if you're going to use dual antiplatelets, there is some evidence to use it immediately, but not in the long term. And that would fit with the sense that in the acute phase, risk is so high that just a little bit more help can give you some overall benefit, and you can absorb the extra risk of hemorrhage. Whereas in the long term, you don't have as much to save, but you've got more to lose.